Hello friends, let us now learn some important points about the drugs acting on bone. So, we have two different types of drugs acting on bone which will inhibit bone resorption and which will activate bone formation. In drugs which inhibit bone resorption, first we have denosumab. Denosumab will inhibit rank ligand, and the drugs which induces apoptosis of osteoclast, which includes bisphosphonates. And then we have selective estrogen receptor modulators, which include raloxifene and bazidoxifene. Then we have calcitonin analog, which includes salcaltonin. Then, if you see the drugs which activate bone formation, these will activate osteoblasts, which include teriparatide, abaloparatide, and we also have anti-sclerostin monoclonal antibody called as Romosuzumab. Now, the side effects of these drugs is most commonly they cause hypocalcemia, whereas a drug which is both causes bone resorption and bone formation is Strontium Rhaenylate. First, we will learn about denosumab. This is an anti-rank ligand monoclonal antibody. It is administered with the help of subcutaneous route. This is used for osteoporosis for 3 to 5 years. Then it is used for treatment of drug resistant postmenopausal osteoporosis, for giant cell tumor hypercalcemia associated with pregnancy, and it is all on or hyperparathyroidism. It is also used in prevention of bone metastasis in prostate cancer. Side effects are denosumab causes osteoporosis of jaw. It causes fracture femur, dermatitis, secondary cancer, and pancreatitis. Then the next drug which is important is bisphosphonates. These bisphosphonates will bind to the hydroxyapatite crystals of the bone when the osteoclasts attach to the bone matrix during resorption process. During that time, these bisphosphonates will bind to the hydroxyapatite crystals. So bisphosphonates are released from the bones and they are internalized by the endocytosis into the osteoclasts. That means osteoclasts will eat the bisphosphonates, and this will result in osteoclastic apoptosis, and they will also inhibit the release of interleukin 6, which will inhibit the differentiation of osteoclastic precursors, thus inhibiting osteoclastic resorption on a whole. So, we will see pharmacokinetics. They have poor oral bioavailability and food decreases absorption. So, we will have to take these bisphosphonates only on the empty stomach with full glass of water. So, side effects are these bisphosphonates can cause esophagitis, especially with oral drugs. So, we will have to advise to take the drug after overnight fasting, followed by full glass of water. We will have to take the drug with overnight fasting followed by full glass of water, and you should ask the person not to lie down for 30 minutes. Then we have osteonecrosis of jaw has side effect, which is seen maximum with zoledronate. Then other side effect is hypocalcemia, which is maximum with zoledronate, and it has fastest action with salcaltonin. Then this hypocalcemia can also cause seizures, or it can also cause femoral chalk stick fracture leading to bone pain. Then we have bisphosphonates drugs. Bisphosphonates can be divided into 3 generations. So first generation includes drugs like etidronate, teludronate. Second generations include pamidronate, alendronate, and ibandronate, whereas third generation drugs include risedronate and zoledronate. So these drugs, that is alendronate, ibandronate, and risedronate, are oral. Zoledronate is the longest acting and most potent and parenteral. Pamidronate is parenteral. These first generation bisphosphonates can cause osteomalacia. So all these bisphosphonates are contraindicated in gastroesophageal reflux disease, peptic ulcer and renal failure. Uses are, they are actually drug of choice for the treatment of osteoporosis, and they are given for the duration of 3 to 5 years. Half-life in the bone is 10 years, and we mainly prefer the drug zoledronate is mainly preferred among all these bisphosphonates. Then because it is long acting and most potent, then preferred drug in glucocorticoid induced osteoporosis is alendronate. Then we can also use these bisphosphonates in Paget's disease, hypercalcemia of malignancy, and also hypercalcemia of hyperparathyroidism. Then the next important thing is about the selective estrogen receptor modulators. So the selective estrogen receptor modulators are include mainly the two drugs. One we have raloxifene and the second we have bazidoxifene. This raloxifene is used for the treatment and prophylaxis of postmenopausal osteoporosis. The side effects of raloxifene include thrombosis and hot flushes, whereas this bazidoxifene is used for the prophylaxis of postoperative osteoporosis in patients with intact uterus. Remember, always in intact uterus we do bazidoxifene. If uterus is absent, then we give raloxifene. Then if you see the next group of drugs, that is calcitonin analogues. These include, first we have calcitonin. This calcitonin has subcutaneously, it is used in the treatment of Paget's disease IV in prophylaxis of osteoporosis. This calcitonin has analgesic effect in vertebral fractures. If you see the side effects, these are the fastest drugs which can cause hypocalcemia. The other side effect is cancer. They increase the risk of liver cancer, whereas they decrease the risk of breast cancer. Then we have the next group of drugs which are parathyroid analogues. In the parathyroid analogues, we have two drugs. One is teriparatide, which is a parathyroid analog directly, whereas we also have abcloparitide, which is a parathyroid peptide analog. Abcloparitide is parathyroid peptide analog. Then if you see the mechanism of action, they cause bone resorption, thus increases the bone formation, thus supplementing calcium. They also transiently cause hypercalcemia. If you see the uses, they can be used subcutaneously for osteoporosis of hypogonadism of postmenopausal men and women. They can be used subcutaneously even in severe osteoporosis. In high risk fractures, they can be used in bisphosphonates induced femoral chalk stick fractures. Bisphosphonate induced femoral chalk stick fracture, we use this parathyroid analogues. Side effects are osteosarcoma, which has black box warning. So this is contraindicated in Paget's disease. The maximum duration of the therapy should be only for 2 years. These can also cause hypotension and pneumonia. The next group of drug is Strontium Rhaenylate, which will resemble calcium and rhanelic acid. If you see the mechanism of action, this Strontium Rhaenylate will move into the bone matrix and increase the bone formation, and it will also go into the osteoclasts and decrease the bone resorption. So it has both bone formation and bone resorption effects, and it is used in osteoporosis. Then the drug is cinacalcet. This cinacalcet is a calcimimetic drug which acts by directly activating the calcium sensing receptors which are present on the parathyroid gland. This drug is approved for the treatment of secondary hyperparathyroidism, and also it is used for the treatment of hypercalcemia, which is associated with parathyroid carcinoma. So The next drug is pilomycin or mithramycin. Pilomycin or mithramycin will inhibit bone resorption. It is used in Paget's disease and also in hypercalcemia. Then the next drug is Romosuzumab. Romosuzumab is FDA approved in 2019. It is an anti-sclerotic monoclonal antibody which will increase the bone formation. It is used in the treatment of osteoporosis in postmenopausal female with high risk of osteoporosis. Then the last drug is Gallium Nitrate, which inhibits bone resorption, and it is used in the treatment of Paget's disease and hypercalcemia of malignancy. Side effects are because it causes nephrotoxicity, we do not use it often. So this is about the drugs which are acting on the bone. Thank you for watching.